Hi, everybody. Thanks for joining us today. Welcome to the 5th Town Hall Series, Be Well, Virginia. For those of you who haven't met me, my name's Jessica Ware. I'm the physician assistant at Northern Virginia Family Practice. Today, I'm joined with Dr. Beauvais and Dr. Azita Moalemi. They'll be both updating us on the complications of COVID-19, including cardiovascular complications and manifestations that you might see with the illness. Some of you might not know that Dr. Beauvais, besides having her MD degree, also has a Master's of Public Health from the University of Connecticut. And she's really been instrumental in helping Northern Virginia Family Practice develop policies and procedures during this pandemic. Joining us, in addition to Dr. Beauvais, is Dr. Azita Moalemi, who's one of our valued and amazing colleagues here in Virginia. Dr. Moalemi went to medical school at the University of Maryland School of Medicine. She completed her residencies at George Washington University and Mount Sinai University in New York. She also was a senior cardiology research fellow at NIH and has additional training in nuclear cardiology and cardiac MRI. Dr. Moalemi is the president of Amelia Heart and Vascular Center in Springfield, Virginia, and she's been voted top doctor by Washingtonian Magazine. In addition to being a valued referral source and colleague, she's become a friend over the years to both Dr. Beauvais and I, and we're so excited to have her here with us. Welcome to you.
Thank you. Thank you very much.
Yeah, thank you, Jessica. We did this mini conference this morning. This afternoon we had about 60 people here. We'll see kind of who tunes in today. We're gonna change the method that we used this morning, this afternoon, and hopefully make it a little bit more conversational. Dr. Moalemi is a fantastic storyteller, and she has 1,000 stories in her pocket about extremely compelling patients and the medicine and the medical care and the decision-making that goes around them. The way that I met Dr. Moalemi was probably because of this storytelling. We were both in the cardiac ICU at Alexandria Hospital visiting different patients, and she was talking on the phone with a consultant or maybe talking directly to the primary attending, and she was giving her advice as the cardiac consultant, and she was just so sharp and scientific and thorough that I started listening to what she was talking about. And she wasn't attending on my patient, but she's so incredibly gracious and magnanimous that pretty quickly we reached out to each other and became friends, and I'm guessing that was about a decade ago. We had planned to go work on our storytelling together in Boston at a medical writing conference a month ago, which has gotten sidelined temporarily, but hopefully we'll revisit that. And we'll try to work this in a way that helps you see what we see as primary care doctors, which is that strong relationships with our consultants, our cardiologists and nephrologists and pulmonary doctors, et cetera, really help us provide better primary care medicine. Because when we really understand the diseases that we are trying to prevent, we are a lot more emphatic about preventing them. And so I think if, my connection with Dr. Moalemi is so important, because when I talk to her about what's going on with a patient, she really shows me, we shouldn't accept even 20% of whatever this risk factor is. We need to get it down as low as possible so that these people actually don't wind up in her office. And then she's really trying to talk herself out of a job. So little bit of summaries of some of the topics that we'll get to today include hypertension, and that's been in the news many times about why is hypertension a risk factor for this particular infection. Inflammation plays a big role in typical cardiac disease in both strokes and in coronary artery disease. And inflammation plays a giant role in the development and of the severity of the COVID-19 disease. So we'll try to kind of focus on that as it relates to the heart. We may be able to get to, well, I'm sure we'll be able to get to the ACE and ARB question, which is a blood pressure medicine type called ACE inhibitors, which have been in a lot of controversy. And they're a wonderful example of how the science of COVID is completely evolving. And so what we might read about and think today may be very different in 2 weeks. And so it's important that we continually stay on top of the evolving science and understand better how to steer our patients in, as the science is more clearly understood. We'll also probably talk a little about prevention, cardiac preventive medications, and specifically anticoagulants, because clotting is a big part of the COVID illness as well. So Dr. Moalemi, did you want to start with a slide and talk about that first?
Yeah.
So I'll do the screen sharing. I've got it all. Yeah, I'll share my screen for those of you who would like to see. We'll see if I can get to this, the right thing that I'm trying to find.
And now you know how I felt earlier at 3 o'clock.
That's right. Yeah. Okay.
Better you than me.
Give me a thumbs up if we can see that, guys. You can see it?
Yeah.
Yes, a thumbs up.
We
Okay.
can see it.
Okay.
Yeah.
So
But if you
this is
make
not
it
the
in
slide
a
we're starting
slide
on.
mode, can you make it in a slideshow mode so it looks big? Do you know what I mean?
No, I can't. I can't because I can't. I'll get into the details later, but no, sorry. So,
That's fine.
so go ahead, Dr. Moalemi.
Okay, so a little bit of introduction also on our end. Natasha and I have known each other for a little more than a decade, and you know we have a group called GEMS, Girls Engaged in the Medical Sciences, and every few months we get together for a talk, and then we sort of collaborate and commiserate, as they say. And what I wanted to say is, you know, when we started our friendships, me and her and Dr. Havert and Jessica Ware, we were all younger and with younger families. And I remember, Natasha, you brought your baby one time to GEMS.
Oh,
and we had so many commitments. Remember that? You know, we had commitments inside and outside the home, but they still made it happen. But now that we're a little older, our kids are a little older, and we're able to, you know, sort of communicate with each other more. And we were hoping to go on this trip together. It didn't happen. Hopefully it'll happen in the future, very near future. Okay, I'm sorry. My dog is barking. I want to make sure that, Emma. So I wanted to just go briefly on this virus, talk about it. And I put up this slide because people have heard about SARS and MERS, and of course the COVID-19 and the common cold virus, because coronaviruses can also give you the common cold. And there are 4 variants. I'm sorry, 1 second.
So actually, while we're waiting, we wanted to see if people could get comfortable using the chat box at the bottom of your screen. So are you able to see that if I'm still sharing my screen? Can you see your chat boxes, thumbs up or no? Yes, okay. So if you could type into your chat box, we'd like to know, first of all, how many of you know someone directly who has had the coronavirus? And I'll make sure I can see the chat box coming up on my screen. So if you can just write in there, I have, or I haven't. Dr. Moalemi, we are getting feedback from people about how many people know someone who has had the coronavirus.
Okay, yeah. So do we have a lot of people saying that? Saying yes?
Well, while I'm screen sharing, I have to learn how to find what they're saying. But I'll.
Oh, I see a no. No. So most people say no. How many of you know a person who has had heart disease?
So type in your responses.
To heart disease. Yes, yes, yes. So many, many yeses, right? So, that's got to be one lesson. Heart disease is much more common than COVID-19, and it still remains number one cause of death in the United States and the world. So in spite of having a pandemic that is very scary and causing many, many deaths, unnecessary ones, we have to still remember that heart disease kills more young, middle-aged, and old people than almost all diseases combined. And so for that matter, because heart disease is still number one, we shouldn't forget about it. And second, now it's becoming even more important since COVID-19 is contributing to cardiovascular deaths even more. The main mechanism of COVID-19 mortality is pulmonary, but mainly cardiovascular. And I think this is befitting. I'm going back to that slide. The main point I wanted to make to that slide is that the morphology of COVID-19 is very similar to the coronavirus that causes the common cold, to the SARS that was described in 2002, 2003, and affected 8,000 people who subsequently, 800 of which died, but then it disappeared. And the MERS, which is the Middle Eastern respiratory virus that also causes significant mortality. 30% of people who get MERS die, but it is relatively well contained and not as contagious. So and then the morphology is very similar to this bat coronavirus, but not identical. So we're not exactly sure where it came from or whether it came from bats and then it mutated. This is important because of the testing. So, the false positive and false negative testing for the both the nucleic acid test and also antibody, that there would be some cross-reactivity with these other viruses, especially the common cold virus. So that's important to keep in mind that, if you do the test and you don't have the antibody, doesn't mean you didn't catch the disease. And if you do have the antibody, there's still some chance that you have the antibody to the common cold coronavirus and not to the COVID-19. So you shouldn't get too much of a false sense of security with that. So what do you want to do the next slide, Natasha?
Yes, except I'm
Lost.
lost. Yeah, here we go. There we go. Coming. That's a mess. There we go.
Yeah, that one is a good one. Okay, so you guys have seen the picture of this virus from all sorts of, CNN and ABC and all the news. But it's important to actually talk about what this picture represents. So you have the actual spike protein. The spike protein is called the spike glycoprotein. It binds a protein called ACE2, the cell receptor ACE2. And that's where the cardiovascular problem of this virus comes, because ACE2 is very important in our cardiovascular homeostasis, in us being able to regulate our blood pressure and heart rate, and the right mix of basically proteins that help us, have the fight or flight response appropriately in our body. And then it has this membrane glycoprotein and an envelope. And those components are important for the virus to be able to embed itself into the human cells, get inside the human cells, and then reproduce itself. And then you have the nucleocapsid protein, which is the protein that's bound to the RNA of the virus. This is a single strand RNA virus it's called positive sense virus, which means that it can reproduce itself without the help of the host, as opposed to other viruses that need the help of the host to reproduce. So it goes into the nucleus of the human cell, and there it reproduces into billions of virions. And then subsequently, again, with the help of that envelope, a membrane glycoprotein, it buds itself out and goes into the bloodstream and the systemic circulation. So that's in a nutshell how this virus reacts.
So something we wanted to point out, I think, Azita, was that when we're trying to create either testing for this disease, testing for the RNA itself, or we're trying to create vaccines for this disease, there are a few places where you might read about this making sense. One is that we're trying to look at some spike proteins to have an antibody against the spike protein. I think another one you had described before was against this envelope protein, with the envelope kind of pushes or is the doorway through which the cell joins our human cells. And there was a third area you were talking about earlier. What was that?
So, you can make the vaccine against any one of these components, which are the structural components, because the virus has some RNA, coding areas that does not code for structural proteins, but code for its ability to make itself. And so you can make the vaccine against any of these components, and it's the fewer those components, the easier it is to make the vaccine. But then you run into the problem of the virus mutating. So if the virus mutates and it changes the shape of its spike glycoprotein, then your vaccine wouldn't work. If you make the vaccine against the entire virus and you inactivate the virus, that's when it works the best. But then you run into the fact that if one of your little virions is not fully inactivated, then that person can become sick from it, and especially immunocompromised people. So when you have an inactivated, or what do they call a live attenuated vaccine, you run the risk of making that person sick.
So I just want to switch back to the original slide for 1 second and just explain one part here. And I think if we look at this yellow strip, you can see how much commonality there is between these conditions. And I think the top one is the common cold. Is that right, Dr. Moalemi?
Correct. Yeah. Sure.
So can you explain what happens? Like, for example, the current antibody test, which we have at our office, is frankly lousy and has a very huge crossover likelihood with other types of coronaviruses. So if a person tests positive, it's not clear that they're testing positive for this COVID-19 virus.
Yeah, and I looked at the literature to see what's the commonality of the coronavirus cold virus, because you have your other viruses like the Coxsackie B, and you have the one that affects kids. I forget the name. Was it from RSV, right? So there are all these other viruses that affect us, but it's anywhere between, the literature is anywhere between 8 and 40% incidence of cold coming from corona, depending on where you are, what the season is, what the year is, and so forth. So potentially, you could have been exposed to coronavirus, and then when you get tested for the antibody for COVID, you'll test positive and you think, oh, I must have caught COVID and now I'm good. But then again, there is 8 to 40% chance you're not, and that you could catch the real COVID. The difference between that is that, COVID binds to your ACE2 receptor and wreaks havoc in your body. The other coronaviruses, the 4 coronaviruses, only one binds to ACE2, and very weakly it binds. That's why it doesn't make you as sick. So that's why you have to understand the difference.
Yeah, so I think right now at this stage of development of the antibody testing, it's really still developmental. And to confirm that, I spoke with 2 panels this week with other doctors nationwide on one call, and another one was with a doctor who runs the ICUs at Fairfax Hospital. And he explained to us that they're even testing patients who have been known to test positive first and then recover from the disease and then come into their plasma donation program. Those patients are not testing the way they should be testing with the antibody testing that's available at Fairfax Hospital. So we are not using antibody testing to steer any decision making yet because it's unreliable.
Yeah. I think it would be reassuring if you were COVID-19 positive and then you're antibody positive, you probably could say, yes, I caught it and I have some immunity. But in absence of that, I think it would be very hard to make that assumption.
Mm-hmm. Right.
Yeah,
and actually, we're only assuming the part about immunity. We don't know anything about immunity from the antibody test. The antibody test does show us, if it were an accurate test in an ideal world, it would be great because it would show us whether we had actually been exposed to this virus, which would be quite reassuring, because if we are getting that test and it tests that we had that illness, we've lived through it. And so that would be fantastic. You know, we would know that we could live through it. It doesn't necessarily mean we're immune to it or that we're not carrying it to others. So number one, the test is not good anyway. And number two, if it were good, it wouldn't tell us what we want to know, which is, are we transmitting this to others and could we get it again?
Yeah. Now, what is important though is to know that the transmissibility is up to 21 days and as far out as 27 days. So it's quite unlikely that if you had the virus more than a month ago that you can transmit it, that you're okay. Because we saw a patient about 34 days ago, and we did a test. The patient came in with chest pain, and we did a stress test. Then we got a call from the health department saying that patient had tested positive 6 days ago with COVID-19, and they wanted to identify all the workers in our office who had been exposed to him. And I was like, 6 days ago, we saw the man 35 days ago. So 29 days between that time, he could not have been positive at that time. So they were, then they said, oh, yeah, you're right. Okay. So it was just, they're a little flawed in their tracking of the cases. On the other hand, a patient of mine went to the hospital with some diarrhea, which I will talk about again in a moment, with diarrhea and a little low-grade fever. She has heart failure. She was feeling short of breath too. And they tested her for COVID-19. They gave her some Lasix because she was in a little bit of heart failure, sent her home and told her that they would call her. And they called her a day later, left a message in her answering machine, in her voicemail in English. She's Spanish speaking at 8 o'clock at night. Nobody got that information. Nobody knew that. And then, 4 days later, her daughter got sick and then her grandchild got sick. So it transmitted. So that communication was never happened, which was inappropriate. And I think that's one area where our health department needs to get a little better at, to identify the right people and notify the right people with that regard. But that patient did well. Her children did well. Her grandchild did well too. They all did okay.
Yeah, I think that's reassuring. Dr. Moalemi, you talked earlier today about some elderly people that you have treated for multiple cardiac conditions that have survived this disease. And I think it is hopeful to people who are walking around with something that makes them in a higher risk category to realize that they can survive this. So maybe you could share that story.
Yeah, so let me tell you, first of all, even in patients who have high mortality, if you look at the Wuhan experience, the general population risk of dying from the disease is 2.3%. If you're over the age of 80, your risk is 14.5%. So it's a lot higher, 7 times the general population. But it's still, that means 86% of people over the age of 80 will survive it. Now, what we have noticed in our patient population who are sick. They have diabetes, hypertension, heart failure, they've had bypass surgery. They generally are ex-smokers or active smokers. We have had many, multiple patients who have had COVID-19, and thankfully we haven't lost any of them. And I wonder whether it has to do with the fact, and I know that it has to do with the fact that the risk factors are controlled, that they're on the right medications, and that I'm sure has something to do with it. So in that spirit, we did want to talk about the people who are most vulnerable to get this disease. And those are people who have high blood pressure, hypertension, diabetes, obesity, history of heart disease in the past, a history of underlying lung disease, and the smokers.
Maybe take hypertension first.
Yeah, so let's take hypertension. You were talking about, how in the HIV era, when we, Dr. Beauvais and I were talking about how we trained at the time when HIV was the biggest epidemic. And it was as unknown and as scary as COVID-19 is now. And actually, HIV claimed the lives of 36 million people, mostly young. And yet we were able to figure it out. It took a while, but we figured it out. But one of the things about HIV is the genetic predisposition, where genes come into factor here. And we think maybe COVID-19 is like that. So about hypertension, we are seeing this discrepant mortality between blacks and whites who have hypertension. And the question is whether that has to do with genes, because maybe blacks have more ACE2 levels in their body, or if it has to do with socioeconomic status, perhaps not access to care, not access to good medications. But hypertension is a big one. And hypertension, the main mechanism of hypertension is ACE-mediated, that angiotensin converting enzyme inhibitors are used for treatment of hypertension. And,
just to back up to make sure everyone is following us. So when we treat hypertension, we can treat it with something called ACE inhibitors, which interfere with this process that Dr. Moalemi will describe, or we can treat it with other types of medications. And we use different medications partly for their benefit to certain populations and partly for their beneficial side effects for other conditions that we're treating. And so the ACE inhibitor that she's going to talk about directly interferes with the same receptor that the COVID virus binds to. So she's going to explain kind of how that receptor relationship works and how ACE inhibitors work in everyday people, and why our science has changed about ACE inhibitors and COVID. Now, Dr. Moalemi, you're muted still.
Mute myself.
There you go.
Okay. So, one of the ways that this virus actually works is by attacking your immune system. I'm sorry, my battery is running out. I got to get a charger. I'll be right back.
The technical tricks of video conferencing from home. So we had a challenge last week to see if we could artfully figure out how to entertain people's real-time questions, which I had not yet figured out in our first month of hosting these calls, but I will try today. So if you have a question, a real-time question for Dr. Moalemi, then please use the same chat box that you used earlier. You hover over your screen, and at the bottom there's that chat box, and I will do my best to try to look at those real-time questions.
Okay, found my charger. Okay. So we looked at the structure of that protein. You saw that spike protein. That spike protein attaches to a protein called the ACE2 in our lung cells. It has a there we go. So, so this ACE2 protein lines are epithelial lung cells. The way the virus initially enters your body is that it escapes your initial innate immunity response. You don't shed the virus, you don't get a runny nose, you don't get a cough. These are usual immunity walls that your body creates to get rid of the virus before it can even enter your body. The cold, when you catch a cold, you start getting runny nose, runny eyes, you cough, you feel a little miserable, but that's a good thing because your body is trying to react to the virus and trying to wall it off. But eventually some of that virus gets in you, and when you have a cold and you get this immunity to these cells called T cells. And the T cells release these chemokines and cytokines. These are little molecules that alert your immune system to fight this virus. And then you release these cells as a result of these messenger proteins to go and attack the virus and eat it up, okay? Eventually, you also create real specific antibody towards the virus. Those are called B memory cells. And so that in the future, when that virus attacks you, you have a memory of it and you can act quicker and not catch the illness at all. Well, unfortunately for this COVID-19 escapes your innate immunity. It hides in your system for 5 days. You feel absolutely nothing. You're feeling good. And then all of a sudden you get short of breath and you get this fever. And the reason is because it goes inside the lungs and then attaches to this ACE2 protein, gets into the cell and replicates into billions, and then it sticks its ugly head out. And once it comes out, then your body says, oops, and it realizes that it's in big trouble and releases this massive amount of cytokines and chemokines, these messenger proteins, to alert the body that something is wrong. Now, those messenger proteins are very inflammatory and they're hypercoagulable. So that's why the lungs, get full of this, they call ground glass appearance on CAT scan. They're very inflamed, and then your body starts making clots. So a lot of patients with this condition are getting pulmonary embolism, they're getting strokes, they're getting clots that go to their legs, and they're getting heart attacks from the blood clots. That's the mechanism for the cardiovascular complications. When patients come into the hospital, we can test to see if they have injury to their heart muscle by a test called troponin. And if your troponin is positive and you have COVID-19, your risk of mortality, dying from the illness, is extremely high. How does it affect the heart? Well, multiple mechanisms. The heart also has ACE2 protein. So this virus can directly attack the muscle of your heart and make it weak. That's called cardiomyopathy. Cardio, the heart, myo, muscle, pathy means weak. So your heart muscle can become weak because the virus directly attack the muscle. The second mechanism, yeah.
Azita, I'm just going to pause us for a second and just kind of do a quick kind of primary care recap. So first of all, before we even get the virus, if we're managing our conditions well and our blood pressure well, we are much less likely to have what Dr. Moalemi is talking about with the inflammatory responses, or maybe we're just as likely to have them, but we're less susceptible to them because our blood vessels, when we're really controlling our blood pressure and preventing our cholesterol from migrating and helping our blood stay as thin as it's supposed to be, when we are doing that, we're preventing damage to our blood vessels. So part of what happens in an inflammatory state is that we get extra swelling all over the tissue. And if we start with intact blood vessels and well-controlled blood pressure, we're in a much better place than if we start with uncontrolled blood pressure, which would then mean that we had little bits of microscopic tears in our blood vessels that would make us predisposed to inflammation and the effects of inflammation. And then Dr. Moalemi, a very apropos question came in So I'm answering a real-time question. I'm very proud of myself about ACE inhibitors. Specifically, what are your current recommendations on ACE inhibitors? Lisinopril is an ACE inhibitor. You can name all the names.
Yeah, so anything that ends in pril, like lisinopril, fosinopril, ramipril, those are all ACE inhibitors. And then we have angiotensin receptor blockers, which work very similar way, like losartan, valsartan, olmesartan. Now, there was this theory that if you bind the ACE2 receptor, you will upregulate ACE2. You will make more ACE2 if you're on an ACE inhibitor. And if you make more ACE2, then the virus has more substrate to bind to, and therefore you will encourage more viral replication. Now, that has never been actually proven. Maybe they saw it some mouse model. And so initially people were saying, well, should people be on ACE inhibitors and angiotensin receptor blockers? But then when they looked at it, they noticed that the ACE and ACE2 are two different molecules and they balance each other. ACE2 is the good guy, ACE is the bad guy. When you get rid of the good guy, now you have an unbalanced bad guy, which is the ACE. If you give ACE inhibitors, then you actually reduce your risk of having clotting and those inflammatory markers. So now there is this idea that actually ACE inhibitors are good, that we should give it to patients. And there's a trial going on looking at ACE inhibitors to give it to COVID-19 patients who don't have high blood pressure, just to prevent this inflammatory and hypercoagulability response. So if you are on ACE2 inhibitors, don't stop it. In fact, be happy you're taking it. Take your angiotensin receptor blockers and your ACE2 inhibitors. These are good things. And I wonder if our patients who have done well with COVID-19 are doing well because their risk factors are so well controlled. I saw a question about obesity and whether obesity is a risk factor. And the answer is yes, okay? And that has so many challenges to it. You know, there's so many factors that involve obesity and why obesity is a major risk factor. For one, you know, you and I were talking about presentation of COVID, and COVID can present like diarrhea. And the reason is that ACE2 exists on lungs, the heart, the stomach, the brain, and the vessels, the lining of our vessels. So when it binds the gut, it causes the symptoms in the gut. Now, it turns out there is a lot of association between inflammation in our body and the gut biome, those good bacteria that live in our guts. And those bacteria are not the right balance in people who are obese. You know, perhaps because of the diets that we follow or whatever have you, that in itself is a risk factor. So one of the reasons why obesity may be a risk factor is because of a higher binding of this virus to the ACE2 levels in the guts.
Yeah, I think there's many theories about that. And I think, of course, it's not completely understood, but another thing that can happen in people who are heavy is, you know, we all gain a little bit of weight on our bellies or our hips or our breasts or our legs or something. And what we can't see is that we also gain a little bit of weight inside the rib cage. And so people who are overweight actually are usually not able to expand their lungs quite as much as they would if their weight were normal. Now, of course, just like everyone is a different body shape, the way that fat distributes inside the rib cage is different for everyone. So it's not a uniform type of a situation, but it is a little bit of a mechanical limitation in how much breath we can get. And so if there's an inflammatory process that's impacting our lungs, that would be another factor. So while Dr. Moalemi is out, oh, she's coming back. Okay. So I also just talked about the mechanical disadvantage if people are heavy and they have a little bit of fat tissue inside their rib cage, their pulmonary capacity is smaller.
Yeah, that's a big factor as well, right? The tidal volume and how much, capacity you have. As you know, you can take a person's lung, one lung, and they will survive. That's why when we do lung transplant, we only give one lung. So we have a lot of lung capacity, but anything that you take away from that capacity, for example, patients with chronic obstructive lung disease are at high risk for this virus because they already have reduced lung capacity. So anything you can do to improve that, and in that realm, exercise comes into place, because people who exercise and do even meditation or yoga, they have a bigger lung capacity, and they can use more of that surface. So if they lose a little bit of it, it won't kill them. Other risk factors.
She's planting a seed for what I'm going to tell you about later, which is our free online exercise class, which after she heard about it, she decided to sign up for. So we'll tell you about that at the end. And then Dr. Moalemi, we did get sidetracked a little bit. Could you go back to clotting? And first, maybe just talk about the kind of normal prevention that we do for cardiac conditions, both strokes and heart attacks. And then what is the kind of inflammatory response that we see in some patients with severe COVID, and how cardiac medications may actually help prevent those side effects.
So if you come to us and we determine that you actually have heart disease, you have coronary disease, what are we saying? We're saying that one of your blood vessels or more of your blood vessels, either in your heart, your brain, or your periphery, have plaque, they have cholesterol buildup. And if they have cholesterol buildup, well, what happens to that? Well, you're at risk that at one point, one of these plaques, these buildup of cholesterol in your blood vessels of the heart, can increase, or that they can be vulnerable and attract clot. And there is a junction where that blood vessel completely closes, your heart muscle doesn't get enough blood flow, and that's what a myocardial infarction is. So how that happens and why that happens, we don't quite know. But what we know that the risk factors that cause you to have the initial plaque to begin with and the plaque to rupture are diabetes, hypertension, smoking, cholesterol, family history, and a sedentary state. So if we can target those conditions, then we are able to reduce the chance that you would have the plaque and the chance that you would rupture that plaque. And how do we target it? Well, we control blood pressure so you don't get that laceration into your blood vessels, essentially. We target your cholesterol so we can reduce the amount of cholesterol in your bloodstream circulating, and also reduce the likelihood that the plaque that you already have would rupture. And that's the function of the statins. We give you anticoagulation, be it in the form of aspirin, which is an antiplatelet agent, or clopidogrel, or, if you feel like you need bigger anticoagulation, you can get warfarin or Eliquis, one of these drugs that are considered antithrombotic. So that's the mechanism by which we prevent somebody who already has evidence of heart disease from progressing to what we call a cardiovascular event. And a cardiovascular event is heart attack, a stroke, and death. So how do you prevent those? You prevent the underlying cause that causes them.
So this is a plug for everyone to take your medicine. And now we'll reemphasize that by saying why that's important through COVID.
Mm-hmm. And the way COVID causes a heart attack is the way you cause your own heart attack. You have a lot of inflammation. If you're diabetic that's poorly controlled, that sugar milieu causes a lot of inflammation. If you're hypertensive, that is not well controlled. If you have cholesterol that is circulating in your bloodstream, that's all inflammation, and it causes clotting. So unfortunately for COVID victims, when they present, even if they don't have cardiovascular risk factors, or especially if they do have it, they release this massive amount of inflammation. And the mechanism of action of how the heart attack occurs is the same. Now, it does it in many different ways. It can affect your muscle, as we talked about. It can cause you the good old heart attack, the way normal people get it. Their blood vessel clogs up and gives them a heart attack. Their smaller blood vessels can clog up, and that's what's called microvascular disease. And then we have seen this phenomenon of stress-induced cardiomyopathy, where the sheer stress of going through this virus cytokine storm causes the heart to fail. There's a condition called stress-induced cardiomyopathy or broken heart syndrome. The Japanese call it Takotsubo syndrome, which happened before COVID-19. It happens when you have incredible amount of stress, stress that you did not anticipate, and that causes a surge in your catecholamines, in your adrenaline, and that we don't know why and how. The heart suffers huge inflammation, and you present actually to the hospital for all intents and purposes like a heart attack. The EKG shows abnormalities that patients with heart attacks have. When we do sonogram, the heart is weak, like a patient who has had a heart attack. But then you do the heart catheterization and you don't see any blockages. So before COVID-19, I've had, just to give you a little example of the kind of patients who have presented, I have a patient who unfortunately lost her son in the war in Iraq. And when, apparently the military, when they come in and knock on your door, you know why they're knocking. And in that moment in time, she actually collapsed. And then they called 911 and sent her to the hospital. And she was having EKG abnormalities that looked like a heart attack. And, she went into the cath lab and we looked at her coronaries, but they were normal. And she really had Takotsubo cardiomyopathy or stress-induced cardiomyopathy. I had another patient who, she's a very high profile attorney and was working on this really big case in China, was working on it for 2.5 years. She was convinced that everything was going well and they would win the case, and then they lost it. And then when she came back from China, came to US and went to her house, and that night at 2 a.m, she woke up with chest pain and again ended up in the hospital with the same presentation. And then I have a patient who, she's 80 years old. She's been working at an indigent clinic in Alexandria for many, many years. She's a wonderful woman who worked in administration, did a lot of work good for a lot of people. And on her retirement, all these doctors and nurses and social workers who had worked with her over the years, each one of them went up there and gave a speech in her honor and presented her with a rose. And she felt so overwhelmed with emotions that, when she went home after an hour, she had this intense chest pain. And of course, she ended up in the hospital too, and with Takotsubo cardiomyopathy.
So Azita told me these stories after our first call today, and they're just absolutely heart-wrenching, and especially because they're so emotional. I mean, it's really an example of how the psychological effects of something can trigger a physiological response. And I think if we try to look at that maybe in the light of the news we heard about 2 weeks ago, where we were talking about the stress people are experiencing, both from having a pandemic at all, watching the news, from the way their lives are shifting, their inability to see the people that they love, the balance of caring for people that has become much more difficult, whether it's children at home or elderly people and people who are losing jobs and stressed about their finances. I think it's so important for us to talk through that stuff. And this is actually a really, really good time to begin working on your mental health, because you don't have to go to the office to do it. You can do it online through a video. So there's no barrier in terms of transportation and the kind of cumbersomeness of that. So if you can find a private space and reach out to your primary care provider, we can help get you to the right places. These stories, Dr. Moalemi, I'm aware of several people with Takotsubo syndrome who've recovered. I don't know the ends of your stories, but I do know that it is something that that can heal. And I don't know whether we could prevent it adequately by talking through the anticipated experiences that we might have in this kind of a stressful environment. But I do believe that that is so important, if nothing else, for your blood pressure, let alone for preventing that, cardiomyopathy type of a situation.
Well, I mean, Dr. Beauvais, I think that you could potentially prevent it. One of my colleagues who's an interventional cardiologist was telling me that he has seen a couple of cases of this broken heart syndrome. One patient came in with COVID and had, in fact, this Takotsubo syndrome. So COVID itself can cause it, perhaps because you have this cytokine release that is so massive and, associated with that adrenaline surge of not being able to breathe and, having this tube in your lungs and so forth. So that was one. But then another case he saw was a patient who has lost his job. He had just gotten a good job with the travel industry, had bought a new home, has a child in college, and everything was so good. And then all of a sudden, he's out of a job, can't pay his mortgage, child is home. And so that incredible stress caused him to have Takotsubo. And I think, you're right. The social isolation, the loss of jobs, the economic hardships people are going through, but they're going to have to keep it in perspective because, you have all those bad things and now you also have heart disease. And that's bad. so it's just that, we just have to keep it in perspective and try to make it through these hard times, perhaps by, giving each other virtual hugs, so to speak.
So come see Jessica and I so we can help you work out whatever those preventive health needs are, whether it's your cholesterol or your blood pressure or your mental health needs, so that we don't have to keep Dr. Moalemi busy. Dr. Moalemi, one more question on anti-inflammatories. Why is Tylenol better than Aleve? If you could just speak quickly to the other kind of misnomer that started early in COVID, which was that we were not supposed to take ibuprofen. I don't know the data on Aleve versus ibuprofen.
So there's not a whole lot of data, that mostly was it done anecdotally, only because if you go back to the NSAID data, the non-steroidal anti-inflammatory drugs generally cause hypercoagulability. There was an old drug called Vioxx, not too old, but Vioxx was an amazing drug. You gave 50 milligrams to people with arthritis, they loved it. And they could even the commercial, I don't know if you remember, the lady was dancing, but after 2 years, the post-marketing studies showed that it was causing people to have heart attacks and strokes. And sure enough, it works through the non-aspirin pathway, the opposite of aspirin, and it causes you to have blood clots. And it's very ironic because this class of drugs can cause you to have GI bleed, by causing ulcers. So you can bleed and you can clot at the same time. So based on that, the idea thought was this was a hypercoagulable, hyperinflammatory condition, so maybe you shouldn't take NSAIDs. You just generally shouldn't take NSAIDs for the heck of taking NSAIDs just because of the data we have on non-steroidal anti-inflammatory drugs. But if you have a headache, you can have your Advil and not feel too guilty about it.
Yeah. So the answer is, I think it's okay to take, as far as we know, it's okay to take Tylenol or Aleve or ibuprofen for the COVID virus. I think we misunderstood in the beginning that there was a concern about ibuprofen, which has been so far, as of today, debunked, and we can stay tuned what happens in June.
Yeah.
Dr. Moalemi, I was going to give a little bit of a local hospital update because I think our patients have appreciated that recently. One of the doctors I work with is the Dr. Al Holt, who runs the pulmonary and critical care teams through all the Inova hospitals. Most specifically, he's at Fairfax Hospital, and he's coordinating all of the different care teams that have to work throughout their ICUs. And he was explaining last night that the hospital has a 900 bed capacity, but that currently they have 200 patients that are in the ICU there. And typically they wouldn't have that many people in the ICU, and they've kind of reutilized many critical care locations in the hospital. So there's a medical ICU and a cardiac ICU and a neurologic ICU, and there's a post-surgical ICU. And then there are pre-surgical areas that they've kind of converted into new ICUs. So I just wanted to let you know that the numbers in Virginia they're a little better than they were 10 days ago, but they're not yet where they were 2 weeks ago. So we are still in we're still really in a plateau, but the plateau kind of moved up 10 days ago. So where it looked like we were plateauing, and I was thinking, here we are, we've hit the plateau, the numbers in the hospital are going to go down. I was wrong. We had another 60 patients added to the census that week, 2 weeks ago. And I think he was really expressing on behalf of the staff there that it is just extremely demanding work, especially for the nurses. The nurses are carrying, direct contact with patients who need almost all of their attention all day long. The patients are in a lonely situation, so they really need to be taking incredible good physical care of them, but also kind of being their liaison to their decision makers and their caregivers. And it just sounds like something that is usually has some ebb and flow, and right now it doesn't really have the ebb, it's just flowing, and it's exhausting for all of the very specialized people who are trained to work in those situations. So please maintain social distancing. Don't start hanging out with all the people that you're yearning to hang out for quite yet, because our hospitals really need recovery time to let us have room to continue to take care of everyone.
And the other thing is given that factor, you and I talked about this, that we have reached out to these doctors who are on the front line to see what it is we can do. And what they have asked us to do is to be sure that we take care of our patients very well, to make sure that we, attend to their immediate needs, to try to keep them out of the ER to the best of capacity. But if you have to go to ER, you have to go to ER. But in that note, it's really important that you communicate with your doctor, Dr. Beauvais, Harvard, and the group. If you have, illnesses, because COVID-19 came to town, all the other illnesses didn't go away. People still get other pneumonias and infections, urinary tract infections, and chest pains, and shortness of breath, and everything else that was there before is still there. And now we have COVID-19. So we want to make sure that patients understand to reach out to us. We have all these modes of communication. You can come to the office, you can communicate by phone, by video, by whatever have you, so that we can use our expertise to help you stay healthy so you don't end up in the ER in their hands for whatever reason. The surgeries are opening up because there are a lot of patients who are waiting to get these surgeries, people who have had tumors, God forbid, to have to be removed. And we've had patients who needed caths, or they needed their pacemaker generator changed, and we had to be waiting, hoping that the battery doesn't run out. So all of those are actually happening now. But the hospitals are very careful to try to risk stratify patients. If you have surgery, you have to go that same day, 2 hours earlier. They COVID-19 test you. And if you're negative, then they proceed with surgery. They make sure they staff, none of them have fevers, and they minimize the number of people in the rooms, and they clean the operating room. So if you have to have surgery, please don't live in fear. But understand that the hospital is trying to phase in these needs. And so the best we as clinicians can do is to help you stay healthy.
Yeah, so I'll just echo that. I was really surprised from Dr. Holt that was his response to us as well in a conference of doctors throughout the country was, what do we really, I think we primary care physicians, especially the community physicians, feel a little bit like these guys in the hospital are really taking the brunt of this epidemic for all of us, and that we should be doing something clinically to help alleviate that. And I was surprised to hear him say, take care of your patients, make sure you talk to your patients, reach out to people, make sure they really know the science about what's going on and they're not getting their information from something that's incorrect. So I was kind of touched to be asked to do my job. I thought that was that was a wonderful wonderful response from him. And I will say that we've had several patients who've needed to be in the hospital. I've had patients who were admitted to the respiratory ward because they did have a syndrome that where possible COVID could have occurred. They've left the respiratory ward. They don't have COVID. I've had patients who needed surgical procedures. They've had their surgical procedures and come home even before we opened things up a month ago or a week ago, because when those things were needed, we still did them. So I do feel very hopeful that the situation in the hospital is being taken very, very, very seriously. Of course, there's always a concern that going to the hospital would, just like going to the grocery store, cause an infection. I mean, it's absolutely a concern, but I've been pleasantly reassured, at least by the few numbers of patients that I've seen so far that have had to go through that.
Yeah, and there's no real major reported nosocomial. We have had nosocomial infections all along.
What's a nosocomial infection?
Yeah, so these are infections that you get in the hospital, right? Yeah. So you can get a strep, a staph, MRSA, all those good bugs that you can catch in the hospital. So that has existed in the past, but there's no major outbreak of COVID from people who went to the hospital for some other reason and then caught COVID. And that's actually pretty reassuring that hasn't been a major problem. So don't be afraid of the hospitals, but reach out to your doctors for sure.
So I'm going to give a little summary and then also a few little bits of information for the future. I think what I really take home from talking to Dr. Moalemi and also talking to my pulmonary friends is that prevention does help. We can't control everything, but we can at least really take care of ourselves. We can continue to eat healthily. We can continue to exercise at home. We can continue to reach out. You can reach all your doctors online. You don't have to leave your living room. So you could have a follow-up appointment with every single person that you see and make sure you're really up to date with everything so that when you do decide to re-enter the kind of in-person healthcare system, you're kind of in good shape. We are starting an online exercise class, and we'll use the chat box again to just hear from people who in our practice has done the Age Proof Your Body exercise class in person. We had about maybe 80 or 100 people who participated over the last year. If you have, you can say yes. If you haven't, you can say I haven't. And for all those who haven't, I will explain it to you. So Age Proof Your Body was really born out of my recognition of this deer in the headlights look that I would get from older people or people who were not in good shape when I would say, exercise is really going to help X or Y or Z condition. And sometimes they would eye roll, but a lot of times they wouldn't eye roll. They knew they'd heard that before, but they just didn't feel capable of starting something. They were deconditioned or overwhelmed by going into a gym. And so they really didn't know how to begin. So we invented the Age Proof Your Body series based loosely on the workout regimen of Justice Ruth Bader Ginsburg. And so, I've done these workouts and I'm in my 40s, and Ruth Bader Ginsburg is doing them and she's 87, and they benefit both of us. So I believe they're truly for all ages. They are very adaptable. We start small and we increase the level of difficulty of exercises within every exercise. So you could start at A, B, or C level depending on where you you really are in your health. These classes are going to be free for all of our patients. So I want you to be looking out for an email next week. We will start by just introducing the series here at the town hall event. And we will have the physical therapists who designed the program for us online. We'll probably do a little 10-minute demo. You can try it. You know, all you need is a floor and a chair, possibly a mat if you want to get down on the floor. And we'll just take you through 10 minutes of this class, but we really would like you to stay in shape. We don't recommend going to the gym. We want you to figure out how to exercise in your house at home. I'm trying to figure this out. Dr. Moalemi's joining to figure it out. Jessica is a workout queen, so she's already figured it out. So I'd love for you to all join us. We really, really want you to participate in this free class, and you can certainly share it with your friends. Other people are allowed to join. It's just free for our patients. So that's next week. The class will get rolled out on the Monday, the 25th, and I don't believe the time is named yet, but it will be something you can click on and do in your own, in your own time if you're unable to make the live class. And then tomorrow is Thursday. We're moving on Friday. So our office will be closed on Friday. That means the lab will be closed. The computer system will be down for about 12 hours. So we will be available on call for emergencies, but we won't be doing regular medicine on Friday. Our staff will be moving us into the offices on Saturday, and we will be reopening at our new location on Monday. We are carefully reopening very slowly. Our goal is to reach every single person by phone. We will continue your care through video visits or through in person, depending on the person's particular situation. Our physicals are going to be done differently. Our procedures are different in that everyone wears a mask, as everyone should be doing everywhere. As soon as you leave your house, please wear your mask. And we will be asking you to wear a mask in our office, in our lab. And we will also ask you to wash your hands or use the hand sanitizer when you come into our office. Our staff is wearing masks, and we're all wearing gloves, and we have spaced out our office visits so that we have adequate time to make sure that everything has a thorough medical grade cleaning in between every patient. So I don't anticipate seeing a lot of patients in the office next week, but we will start to see more. We have been open this whole time, so we've gotten a sense of what it feels like to do that in a very slow and controlled way, and to keep you safe and to keep our staff safe and to keep ourselves safe. We will be following all of the recommendations to make sure that we can all feel comfortable coming there. The most important thing for all of us is wearing this mask, because that is going to prevent us who could be asymptomatically carrying this. So all of us could potentially carry it and not realize that we don't have it, that we do have it. And so if we all have our masks on and we are unaware that we're carrying this, then we are dramatically less likely to leave droplets on the ground when we are out in public. And so I want you to encourage your family members to wear masks, encourage your friends to wear masks, call all of your relatives from out of state where they have different situations and they're not in hot spots, and explain to them the science behind why wearing masks helps. I think the science explains itself when people really understand what it is, but it's not well understood by everyone. So anyway, be our emissaries of important health news. And so with that, I did want to also thank Jessica, who had done our introduction today, because she's a terrific resource in our office. She has her own primary care concierge medicine practice. I believe she was one of the first physician assistants in the country to do that. And she's also a tremendous resource for the physicians in our practice. We use her very regularly to help us problem solve. So in addition to taking care of her own patients, if I have something complicated and Dr. Moalemi doesn't have the answer, Jessica and I will research it, and she will often put an hour or two into searching answers and kind of helping us come up with a variety of methods or a variety of diagnoses that we should be considering, and help us think carefully about who we should be using as a resource and what we haven't ruled out yet. So she's a really tremendous resource for me. You know, everyone knows that we all talk to each other in the office, and she's certainly a big part of that. And then good luck to Dr. Moalemi's daughter, who's a second-year medical student at George Washington.
Mm-hmm.
About
Yeah,
to take her.
she's taking her sports part 1, so she's stressing out a little bit, and I told her this is the first of many to come, so just get used to it.
That's right.
Yeah, so yeah, we'll see. Fingers crossed she'll do okay. She'll be all right, you know. So thank you so much for inviting me. I enjoyed this. We did a run at 3 o'clock. I think this time it turned out even better. I'm excited about the exercise. So I have a confession to make. I tell my patients to exercise. Exercise is the answer. You got to walk 2 miles a day. And then I come home and there's this inertia that sets in, and you're like, oh, you know, I gotta go. I gotta do these charts. I gotta, you know, make sure the kids are okay. I gotta pay the bills. And so, you know, there's so many reasons not to exercise, never mind the fact that you're very self-aware. You know, you go into these gyms and everybody looks like the old Jane Fonda. So you're like, oh, you know, you're struggling through the first routine. So I'm really excited because this is good. I can do it in my home and, you know, nobody's watching me. And, you know, it's going to be good. So now I can tell my patients, I do it too, so you should do it too. It's going to be good. You're going to feel good. You're going to feel better. You're going to have better strength. It helps your mental health because you release endorphins. So when I do have the time and do it, I really enjoy it. And as far as the masks are concerned, you know, I wanted to do that with you. I told one of my patients who was complaining about this, and she was like, oh my God, you know, now we don't even look the same. You know, we can't even wear makeup to go out, and I can't, you know, and I told her, listen, you know, in the HIV eras, we came up with universal precautions. Nobody, right now, universal precautions are so commonplace, you don't even know where it came from. It came from the HIV era. And
that's right. We used to wear gloves every time we drew blood. Can you believe that?
Exactly, right? You know, we didn't wear gloves. The needles, we used to recap them. There was none of this is stuff that we have in place. Now we have OSHA, we have universal precautions, and it is universal precautions. And so this is going to be hopefully temporary. But, you know, if you wear a mask, I'm protected against you. And if I wear a mask, you're protected against me. This is one of those places where we need to help each other stay healthy. And so you have to become very selfless in that assumption. It's just not only about you. You know, I tell that to my kids, the world does not revolve just around you. So it's going to be all right. And it's going to be a new way of adapting to things. It's okay to wash hands. I miss hugging my patients and shaking hands. But there are other forms of communication, and now I'm able to talk to them online and so forth. So I think it's a new era. It's historical, but you have to trust the medical community, all the religions of the world, whether you're Muslim, Christian, Baha'i, like I am, no matter where you come from, you're praying to your God that the doctors and scientists would find the answer. And so this is where, you know, we come in. It's a big burden on our shoulders, but it will be achieved. It will come. I believe in science, and it will come. You just have to be a little patient. It will happen. Yeah.
That's a great summary. Thank you, Dr. Moalemi, for joining us, and thank you all for sharing your hour with us.